Hello, and welcome to my presentation on trichotillomania. So you're probably asking yourself, what is trichotillomania? Well, the DSM-5 criteria for this condition includes the following: hair loss resulting from recurrent pulling of one's own hair, repeated attempts to decrease or stop hair pulling, significant distress or impairment in social, occupational, or other areas of functioning as a result. The hair pulling or hair loss is not attributable to another medical diagnosis, and the hair pulling is not explained by symptoms of any other psychiatric disorder. On this slide, I've included some key points about trichotillomania. The age of onset is typically between the ages of 10 and 13, and it's more common in females in late adolescence. The lifetime prevalence is about 1% to 3%. Now, the act of hair pulling itself provides a sense of relief, pleasure, or comfort, but then it's usually followed by feelings of embarrassment, shame, or guilt. The hair pulling is often associated with depressive or anxiety conditions, or maybe a habit or a tic. Obsessive behaviors like nail biting, skin or lip picking often coexist. Hair pulling can also be seen in children of all ages after infancy, but in younger children, it's often driven more by habits and temporary stressors. As we know from our clinical experiences, the subjective part of the exam is a crucial time to gather information. On this slide, these are some questions that you'll want to ask your patient and their parent if you suspect trichotillomania. For instance, to the child, you may ask, have you noticed yourself playing with, tugging, or pulling out your hair, even without really thinking about it? Have you ever skipped hanging out with your friends, going to school, or doing activities because of your hair? Have you ever tried to stop pulling and you found it really hard to? And to the parent, you may ask questions like, does your child have trouble focusing, feel anxious or down a lot, or have any habits like blinking or throat clearing? Who are the people at home and at school who can help support your child through this? Moving on to the physical exam, this is what you're likely to see when you examine your patient. You'll see patchy areas of hair loss with irregular borders, broken hairs of varying lengths. The typical affected sites are the scalp, the eyebrows, the eyelashes, and the pubic hair, commonly seen in the easily reached areas of the scalp, and there's not typically inflammation or scarring present. For your differential diagnosis, another condition that tends to look similar to trichotillomania is telogen effluvium. No, this is not a Harry Potter spell. This condition is temporary hair shedding that occurs when a stressor, such as illness, surgery, childbirth, significant stress, medication changes, or nutritional deficiency, causes more hairs than normal to enter the telogen resting phase of the hair cycle. It leads to diffuse hair thinning and increased shedding, but hair typically regrows once the underlying trigger is resolved. Here are a few diagnostics tests you can use to confirm your diagnosis. If you look at hair underneath the microscope, it'll have normal tapered ends. A negative hair pull test is when you gently pull on small sections of hair and it does not result in significant hair loss, suggesting that no excessive shedding was present at the time of the exam. If you're looking for a fungal infection underneath a wood lamp and it's negative, that would also be a sign that this could be trichotillomania. And a punch biopsy would show that the majority of the hairs are in the anagen active growing phase, which is the opposite of what you would see with the differential diagnosis that I mentioned on the previous slide. So you're probably wondering, how do we treat trichotillomania? Well, the best first-line treatment for this condition is behavioral therapy, specifically habit reversal training. This teaches kids to recognize their urges to pull their hair and replace them with other actions like, say, squeezing a stress ball. 76% of kids improve with treatment versus 21% that don't do any treatment. And you really want to get parents on board with the treatment because they, of course, play a key role in their children's lives. Younger kids may do better with simple environmental changes like wearing a hat, gloves, and just keeping their hands busy, and then also using reward systems. And it's really important to ask if the child eats the pulled hair because this can cause really dangerous stomach blockages. So starting treatment early leads to much better outcomes. And while there are no FDA-approved medications for trichotillomania in children, behavior therapy remains the preferred treatment. But SSRIs may be beneficial for children with co-occurring anxiety, depression, or obsessive-compulsive symptoms. If you'd like to learn more about trichotillomania, I've included a list of all the references that I used for my presentation. Thank you so much for listening.